Dr. Patek is going to be discussing how to plan for success in your M1 through M3 year. So take it away.
All right. Well, thank you for getting this set up, and looks like we have a very nice crowd, so that's always encouraging. I'm going to try to share my screen because I have a PowerPoint that I'm going to go through with you all over the next probably 10 to 20 minutes, and then we'll have some time after that for some discussion, questions, and a little Q&A time. So if you have questions, you can save them for later if you want, type them in the chat box, whatever you want to do, and we'll hopefully get to some of those. So I will try to share my screen if I can. Does that look okay? Is it on there? I see it. I hope you all do. Okay, good. All righty. So we're going to basically start out going through essentially sequentially through the MS1 through a little bit of the MS4 year. I don't know how many of each of those we have on the call, but hopefully there's a decent mix of all of them. There's going to be a little overlap with these as we go through them. They're just because you're an MS1 doesn't mean, some of the stuff in the MS2 discussion doesn't apply to you and vice versa. So hopefully this will be valuable regardless of sort of where you are in your career as a medical student. So we'll start out now with the first years. My admonition to the first years is basically seek out first if your school has some shadowing opportunities. That's really the best way to sort of get acquainted with the hospital and the attendees that you want to work with early on. Shadow several different specialties that you might be interested in and start to figure out, I think the best thing to do, especially to figure out what type of medicine you want to go into and spend your career in, is to figure out first if you're sort of a clinic lover or not. If you're a clinic lover, then that obviously kind of sort of pits you in one area, one part of medicine or several different fields of medicine. And then if you're not a clinic lover, then that sort of puts you in sort of a different category. So something to consider. Do you enjoy longitudinal care? Do you like establishing a relationship with your patients? Do you kind of like the idea of shift work? Because if you're on this call and you're interested in emergency medicine, that's our life. Are you okay with having to work some holidays and some nights? Something to pay attention to, especially when you shadow in a teaching hospital, and that's where most of you all are going to be getting your first experiences in a teaching hospital. And especially if they have an EM residency program, recognize that academic emergency medicine and community practice are two pretty different things. So the things that you're going to see, like working in a residency, being in a residency program and shadowing in a residency program is going to be different than what a lot of the community physicians are going to be doing. So just recognize that. And we'll talk a little bit about maybe shadowing in a community setting as well in a bit. When you start allowing, what you want to do is allow yourself to essentially investigate different specialties of medicine early on. Of course, the best way to do that is during your early medical school career. The old adage goes, the best time to plant a tree is 20 years ago. The second best time to plant a tree is now. And so regardless of where you are in your medical career, try to investigate what you want to do as early as possible. Some of the other things you sort of have to recognize about emergency medicine, and some of these isn't necessarily a good thing, but you have to recognize that of all of the specialties within medicine, emergency medicine sort of gets the fishbowl treatment much more than all the other specialties. And so, we sometimes have to make very critical decisions with a lot of with very limited information. And we have to do that obviously in a very brief period of time sometimes. And so when there are bad outcomes, and unfortunately there will be, EM physicians get scrutinized more than just about any other medical specialty. People die when they're in our care, even when all the right decisions are made. And so, what you have to sort of recognize is if you're the type of person who can potentially deal with those types of things, when someone dies or suffers serious harm because of either a diagnostic mistake or just because, death happens. And so those are some of the things you sort of have to recognize in yourself before you decide to make the jump to a career in emergency medicine. Um, the point that I guess in saying all this is just, sort of pay serious consideration to what you want to be and why. And the earlier you start to try to make those decisions, the better. If you have the opportunity during the summer between like your first and second year, for those of you that are first years now, if you have the opportunity, try to shadow a community ED physician, because you'll get to sort of compare and contrast how the academic setting is different than the community setting. So you can see if, in most physicians that go into emergency medicine end up working in the community setting. And so that's going to give you a much more realistic expectation of what you're going to be doing going forward if you go into emergency medicine. All right. Study. I really can't emphasize that enough. Obviously have a little bit of fun, but then study some more. You want to set a really solid foundation for, your medical career. And so the first couple of years of medical school are where you do that. What you're learning is actually really important. Believe it or not, like cardiovascular and respiratory physiology are immensely important, especially when you're trying to understand, taking care of critically ill patients. Pharmacology too is actually important to all physicians, especially emergency medicine physicians. You're going to be reviewing your patient's medications, utilizing and prescribing medications for the rest of your life. So it's obviously important to set a good foundation for yourself as a first and second year medical student. Other things that you may want to consider during the maybe first or second year medical school is to get BLS trained. If your school doesn't require that, seek it out on your own. You never know when your BLS skills may save a life. And if you do like ACLS or PALS, you actually may find out, some of the reasons behind why you're learning what you're learning during the first couple of years of medical school. The other thing is with, and hopefully most of you all have this available to you at the schools that you go to, but join an emergency medicine interest group. If there's one, obviously seek it out. If there isn't one, consider starting one. If there isn't one at your school, you're going to look like a rock star if you start one. If you put that on your residency applications, it's going to look really, really good. So that's something to either seek out or start if you don't have one. Some of the things that you can do through the EMIG groups, bring in guest lecturers, bring in attendings from either community EM attendings or attendings from your from your residency program that's affiliated with your medical school. You can start like a suture skills class. There's nothing more fun than learning how to put in a simple interrupted suture when you're a first year medical student. Like, you get some really good hands-on experience. It makes medicine feel real to you when you do that. And so if you can organize things like that, it just makes everybody that much more positive about what they're doing. The other thing that you can do through an EMIG group is start to foster some mentor and mentee relationships. And so, by bringing in, your academic emergency physicians, by bringing in your emergency medicine residents that are affiliated with your school, that's just going to allow the people that are early on in their careers to be able to establish mentor-mentee relationships. So I think that's something else that's really valuable through the EMIG groups. All right, let's move on to the MS2s. And again, recognize there's going to be some overlap with all this. So just because I'm talking kind of about MS2s doesn't mean it doesn't apply to the 1s and 3s, okay? So again, recognize though, all this stuff that you're doing may apply to you whether you're at the top of the food chain or the bottom of the food chain. So just recognize that. Keep focusing on your studying. You don't want to, and the reason why I say that is you don't really want to pigeonhole yourself of having to go into potentially a less competitive residency program, by doing poorly on your step exams. The other thing too during your second year is you kind of want to start thinking more like a clinician. If you're allowed to do it, do a few more shadow shifts. Go in on a few evenings and weekends for a few hours. You know, if nothing else, this kind of might help your sanity as you're going through your second year of medical school. So this will also, if you haven't found a mentor yet, this may allow you to sort of find a mentor, because you'll obviously be in the department with people that are working. You may find people that you sort of like, you like their personalities, maybe somebody you think you might meld with, and you know, be able to foster that type of relationship with. And that's a good way to find it out if you haven't done it already through like an EMIG group. The other thing to do too during your MS2 year is obviously continue to investigate, you know, other fields of medicine. You know, EM, you may discover during your second year or third year that, you know, emergency medicine may not be for you. So it's just another way of getting more experience and figuring out if what you're doing is if you're going in the right direction for yourself. Obviously focus on doing well on step one. I know you all know this much better than I do because you actually have skin in the game, but you know, whether when you take step one, it's going to be pass or fail, obviously depends. You know, the downside of that is that people are going to start focusing probably more on your step two score. And so all of the things you do that during your first year and second year are going to prepare you for getting a good score on step two. And you want to make sure that, obviously, again, you don't want to pigeonhole yourself going into something you don't want to have to go into just because you have a low step two score. This slide is a bit of an aside. The best way to maybe think about this slide is you're terming it maybe beginning with the end in mind. This is something I never really thought about as a medical student. You know, there are opportunities available to emergency medicine trained physicians beyond just emergency medicine residency. You know, you can get fellowship trained in EMS, tox, pediatric emergency medicine, sports medicine, ultrasound, critical care. And you don't necessarily have to go through a pediatric residency to become a pediatric emergency medicine physician. You don't have to be an internist to go do a critical care fellowship. So think about things, you know, think a little bit outside the box, investigate these things as much as possible. You know, if you're a you know, a third or fourth year medical student, you're thinking, gosh, you know, I want to be a critical care physician. There's more than one avenue to get there. And so just think of those things ahead of time. In my opinion, emergency medicine is a much more enjoyable way to get to critical care than doing an internal medicine residency. So, and again, the end is the same. All right, let's move on to the MS3 year. So I'm not going to spend much time on this for the first part of this, because it sounds like after my little discussion here, you're going to get all you can know about everything you want to know about the alphabet soup here. But some of the things you can do to sort of help yourself along the way during the MS3 year, and obviously when you're going to be in the clinical arena much more now, if you want to investigate you know, emergency medicine more than what you can do, you know, sort of in the clinical arena, you know, go to Journal Club. If your medical school has a residency program associated with it, or if there's a nearby residency program, you know, go to their journal clubs. If you can, from time to time, maybe attend a resident conference. You know, you can consider fraternizing and socializing a little bit as well. And again, this is regardless of what stage you're in school, because, you know, if you're a first year or second year, you can do this too. You don't want to obviously be intrusive or obtrusive when you go into these arenas, but you know, consider going to these the things that the residents go to and where the faculty are as well. At our program, we have pretty regular journal clubs. We meet usually once a month in an attending's home to eat and sort of fellowship and discuss a couple journal articles. And it's a really good time. And we have medical students that join us all the time. And so it's really enjoyable to have people that we don't really know that well, get to know them a little bit better, sort of get to understand their interest in emergency medicine. And it's a good way for them to just get their foot in the door, get known, and you know, and just be part of the group. The other thing that our program does is we have monthly EM wrap discussions. And so, you know, that's sort of a less formal thing than Journal Club, but it's another way to get to know people. So if there's opportunities like that at your institution, try to seek those out and do those if you can. if you find that they don't want you around, then you probably don't want to maybe consider strongly applying to their program. So it's a good way to see if you fit with them. And I seriously doubt that that's going to happen anyway. Most emergency medicine faculty and residents are really going to like to see medical students around, and so you're not going to be a fifth wheel at those events. So don't worry about it. Go and hang out and have fun. This middle section of this slide is actually probably the most important thing that I'm going to talk to you all about. Find out who writes the SLO at your institution. Help them to get to know you. If there's anything that you can do to set yourself up for success during sort of your middle part of your medical student career, it's this. If you're going to go into emergency medicine, the SLO is a really, really important thing for you to have, and to have a good one. So the SLO stands for Standard Letter of Evaluation. It's essentially a standardized form that emergency medicine residency programs use to evaluate people, evaluate the applicants to their program. And so you're going to have a few of these filled out for you when you apply to emergency medicine residency. And so obviously you want to make sure that the person that's writing this knows you well. And so, go out of your way early, find out who this person is. You don't have to camp outside their office, obviously, but make sure you know who it is so that you can introduce yourself to them, express to them that you're interested in going into emergency medicine. And they can give you some insight into what you can do to help yourself going forward. And again, regardless of whether you get much out of the discussion, at least you're going to know who that person is, and they'll get to know you a little bit too. Then probably the second most important thing is when you're doing your clinical experience as a third year, make sure that you take advantage of all of your clinical experiences, because there is nothing that you're going to learn that you probably won't ultimately learn in emergency medicine. We take all comers, we see all kinds of patients, we take care of all kinds of problems. And so, just because you're on your OBGYN rotation or, you're doing something in family medicine that seems mundane, believe me, you're going to find something that you can learn and probably potentially apply going forward. So take advantage of all the clinical opportunities that you get and learn as much as you possibly can. All right. So this was obviously much easier pre-COVID life. You obviously, I remember the good old days. Maybe the fourth years sort of remember the good old days of how it used to be too. But they used to say, hey, all right, do your one home rotation, do at least one away rotation. Now those days are sort of behind us. I'm sure at some point in time we'll get back to those days where this will be sort of true. But now, as you're looking forward to going into fourth year, well, potentially third year or fourth year, sort of depending on when you get exposed to emergency medicine, you're going to have to start thinking outside of the box when it comes to getting as much emergency medicine experience as you possibly can. Because right now, we know that places are only allowing one home rotation. Maybe some of you don't even have a home rotation, so you have to seek one out where you have to get a 4-week elective in emergency medicine so that you can get your SLO filled out, so you can beef up your residency application. Obviously, everything's been really, really challenging for everybody, and so this year more than ever, everybody's sort of stressing out about how they're going to navigate the application process, getting their SLO. Think outside the box. I guess that's what I would, admonish y'all to do as you get closer to this process, depending on where you are in your career. Look into some of the more sort of non-traditional fourth year EM electives. You might want to consider like a 2-week elective in tox. You might want to consider a short elective in ultrasound. We're actually offering those at our institution for our medical students that are going into emergency medicine. They're spending 2 weeks on tox, or spending 2 weeks on ultrasound, and they're getting an additional SLO out of that. The other thing you need to consider, and this is not just to help you, with your residency application, but just getting ready for residency in general. And we'll talk a little bit about this in a bit. Do some tough electives. Do like a critical care elective. Spend time. Do a 4-week trauma elective. Even though you're not going to maybe be a trauma surgeon or a general surgeon going forward, or even an orthopedic surgeon. that experience gets you more, you get to spend more time in the emergency department. You know, I remember when I was a third-year medical student, I really didn't know what I wanted to do. And I was fortunate that essentially my last clerkship was a 12-week surgery clerkship. And the middle 4 weeks of that happened to be in trauma surgery. And of course, where do you spend most of your time on trauma? You spend most of your time down in the emergency department. So it was just very serendipitous that I had the opportunity to spend a bunch of time in the emergency department towards the end of my third year. Otherwise, I don't know if I would have gone into emergency medicine. And so, you know, those experiences, they just give you more opportunity to spend time in the emergency department. So again, just sort of think outside the box of other ways to get more experience, other ways to get in the emergency department. So that's another thing that I would admonish you as you get further into your medical career, especially if we're, you know, continue to be faced with these challenges that COVID has sort of put at our doorstep. Again, this stuff is more for the next presenter, but you know, we'll go on to the next slide here. So how do you prep for your EM rotations? Here's some resources that you all can use. Probably the thing that you want to do as you get into either the third year or fourth year, as you start a clerkship in emergency medicine, read this emergency medicine clerkship primer. The title is right at the top there, Emergency Medicine Clerkship Primer Manual for Medical Students. It's like 130 pages, but it's a really, really easy read. And it gives you a ton of really good information as you step into an emergency medicine clerkship. I'd recommend reading it like 2 or 3 times, because you're going to get new information the second time you read it and the third time you read it. And, you know, just continue to review it, because it's just really, really excellent information. And then, in fact, the end of it has a little bit of what I've already talked about, especially like if you're a first year or second year, you can read it towards the end, because it talks a little bit about sort of the thought process on whether you're sort of a good fit for emergency medicine and whether emergency medicine is a good fit for you. So again, consider reading that early and often. The other things that are on here, you know, Tintinelli, Rosen's, those are sort of the Bibles of emergency medicine. Tintinelli makes a few sort of abbreviated books as well. Those are good resources to have. Most of the time you can get those through your library as ebooks. And so, you know, get familiar with those, because those are really good resources of information as you prep for, and also when you study for, like when you study during your emergency medicine residency, or emergency medicine clerkship rather. There's a lot of really good web-based resources also. They're listed there. EMRAP is really good, but what the main thing you want to focus on is their C3 stuff. That's continuous core content. That's all just the bread and butter emergency medicine. So you don't, you know, you can get sort of bogged down in listening to all the current stuff, but their continuous core content is really where it's at for medical students. So that's what I'd really emphasize for you all. And then there's other things listed there. Life in the Fast Lane is really good. Rebel EM. You know, for people that really like critical care stuff, the mcrit.org is a really good website. So the other thing that I would ask you to at least consider getting, or at least get some of the resources. You don't have to necessarily sign up for the Emergency Medicine Residents Association, but they have some really good apps like the antibiotic guide and things that you could get that are really helpful when you're in your rotation. It's really important for y'all as you get into, you know, the third and fourth year clerkship, kind of depending on when you do it. And most days, I suppose, are all going to be doing fourth year clerkships. Develop, you know, critical thinking skills. That's probably the most important thing that you can do. You know, start to think like an EM physician. Have that worst first mentality. And what that means is, you know, what you want to do is approach a differential with thinking of the things that kill people and maim and harm first. And so, you know the hallmark and sort of the hallmark presenting signs of the worst first things. So like, for example, if you're thinking about chest pain, right? What are the different things that cause chest pain that can kill people? You start thinking about like a tension pneumothorax, you think of cardiac tamponade, you think of acute coronary syndrome, pulmonary embolism, aortic dissection, all of those things that are potential life threats. You should know sort of the hallmark presenting features of those. So when you do present like a chest pain patient to your faculty or to the resident that you're working with, Give them, this is what I think is going on. These are the potential things that could be life threats to the patient. These are why I think that it's not that. This is why I think it could be that. And so those are the ways to approach emergency medicine patients when you're presenting in the emergency department. The other thing to consider too, you also want to, again, give probably what you think is the most reasonable or likely thing, but come to who you're presenting with the plan as well. Tell them, this is what I think is going on with the patient. This is what I want to do to rule out these dangerous things. This is what I want to do to help, sort of establish what's going on with the patient. These are the tests I want to order. This is the imaging test I want to order. I want to order an EKG. I want to order these labs. Know why you want to order those labs. Know why you want to get an EKG. Know why you want to get a chest X-ray or whatever. Know why you want to order those things. When you do those things and you think of those things ahead of time, when you're either challenged on it or you just offer those things up, you're going to look much better presenting those patients than you would if you're not sort of considering those things. And so those are the things to consider, like for you third and fourth years that are, that are either starting or considering going into emergency medicine and doing an EM rotation. Those are the ways that your attending and your resident are going to want you to think. And then how to get ready for residency. For those of you that are fourth years, I assume there probably might be some fourth years that are getting on now to listen to the next presenter, but you can go back to the prior slide, and Blake, you're welcome to send this out to people if they want it, but see the prior slide on your resources that you can use to help you get ready for residency. Because a lot of the same things that get you ready for an EM rotation are going to get you ready for residency as well. We already talked about this, but just work on your critical thinking skills. You might want to consider getting some simulation experience during like third and fourth year, because that really helps you sort of point out some of the gaps in your knowledge base, and then you can go fill those gaps in. And again, like I said before, do some tough rotations. Don't make your fourth year easy. You're going to have downtime during fourth year. You're going to have some easy rotations during fourth year. So challenge yourself with like a trauma rotation, challenge yourself with a critical care rotation. Spend as much time doing, EM stuff that you possibly can, even if it's not strict EM. Obviously critical care, trauma, those are things that are going to prep you for emergency medicine. They might actually get you into the emergency department a little bit more than other rotations would. Like do a peds EM rotation if you can, do the toxin ultrasound rotation if you can. All those things will help you prep for residency, but they'll also help just keep you in the game in the emergency department. So that's pretty much all I have. Hopefully, each of you got maybe one or two little tidbits of information out of that'll help you going forward. I'll take questions if you want. We can put them in the chat box if you want. If you want to, ask it audibly, that's fine. But yeah, I wish you all well wherever you are in your careers, and good luck to you. Enjoy the rest of the talks over the weekend.
If anyone has any questions, we can take those in the chat, or if you want to come on camera and ask them, you're welcome to do that as well.
I saw a
question earlier.
Yeah.
I'm sorry, can you guys hear me? Yeah, okay, sorry. I had a question earlier about, you had kind of mentioned this, that it's a little bit more difficult given the pandemic, but any general advice on how to shadow and get some experience? I'm an MS1, and I would love to have the opportunity to shadow a emergency department physician.
Yeah, so I guess it depends on where you go to school and whether they have an EM residency program with it. If they don't, it might make it a little bit more difficult, but we offer our first years, and I think our second years, the opportunity to shadow. And so I guess the first thing to do is just ask the people that are in your administration at your medical school to see if they allow that. If they do, then obviously that makes it easy. If they don't, and you have to seek it out on your own, maybe the easiest thing to do would just be to, find out some community places in your town, in your city, where they might be accepting of, like MS1s or MS2s going in shadow. I would guess that most places have shadowing opportunities. I don't know that for sure. Our medical school does though, so I don't know what what the consensus is amongst everybody else that's on the call. But yeah, I would just seek it out through your medical school first. If they don't allow it, I would ask why. And obviously if they don't, then you just have to seek it out on your own.
Thank you.
Yeah, 30 years without home institutions. I think that's probably, I'm not an expert on this. I think that's probably going to be something that they're going to discuss over the weekend when you guys get together. Is that correct? Either Lauren or Blake or whoever's on that set this up?
Yes, definitely. And EMRA and CORD have come out with consensus statements as well, at least for people applying this year. But just some things that I've generally heard over the past is just find ways to be as involved as possible. If you don't have a home institution, you can reach out to, bigger, something like TCEP or EMRA and try to get involved on that level, but just show that you're interested however you can.
Yeah, it's challenging. I know there are places around the country that are being intentional on making sure that they have open spots for people who don't, who are orphan, essentially called orphan programs, where they don't have a residency program or essentially a place where they can go to do their rotation at, to get a SLO, because that's really what you're looking for, is to get that SLO written for you so that you have that on your residency application. But yeah, hopefully tune in to the rest of the colloquium over the weekend, and hopefully some of those things will be answered. And the other thing too is look up, I'm not sure who the best resource is going to be for that, but hopefully eventually they'll have some of those things online, where they'll have a list of programs that are agreeable to having students from orphan programs getting in and doing rotations at their facility. Yeah, so there's someone, Lauren, you said that they're going to be talking about doing SIM and things on email groups, which I kind of talked about a little bit as well. Any other questions? I'm trying to look through the chat box to see if we missed anything. Research opportunities. Oh, actually that's really good. I probably should have talked about that. And maybe if I do this at some point in time again, I'll mention that. And I think I may have had it on the slide and I may have just skipped over it, but when you're like a first year or second year, that's another really good way of getting your foot in the door and hanging out in the emergency department. So particularly if you're in an academic setting where they have an EM residency program, the faculty and residents are probably going to be doing research. And so they may need help enrolling patients, collecting data. And so that's just another really good way of getting known, as well as getting sort of your body in the door to be able to just kind of hang out in the emergency department during your first and second year, and just kind of just being there. But it also obviously helps them, and it gives you good research experience to be there to help enroll, or either that or be analyze data, collect data, things like that. So that's a really good point.
All right. Well, thank you so much for joining us, Dr. Patek. If anyone has any final questions, here's your opportunity. But if not, we're going to go ahead and I'm going to hand it over to Angela, who is going to introduce our next speaker.
All right. Thanks, everybody. Enjoy the rest of the time.
Thank you so much.
Thank you. All right, so our next speaker is an assistant professor at the Baylor College of Medicine, and he'll be talking to us about the 4-letter words: STEP, VSAS, ERAS, and probably any other 4-letter word that I can't say in a professional setting. So please welcome Dr. Navdeep Sekhon.
We'll just give him just a second to hop back on. Wow, there's this tiny little break in the talk. There is a small change to tomorrow's schedule. So on the original schedule that I sent you guys out, the health policy talk wasn't going to start until 9:20. It will now start at 9:05 and run until 9:50. So just in case anyone's really interested in that, we have RJ Sontag, Dr. RJ Sontag, who's coming to talk with us, and he's wonderful. He does a lot of talks through EMRA. He's so great. We're super thankful to have him, so everyone should tune in at 9:05 tomorrow morning, right when we get going, and he'll definitely have lots of good stuff to teach us. Does anyone have any questions about anything else tomorrow? I know it's going to be a long day, how anything's going to run. Cool.
Sorry. Hello. Hey, I'm Navdeep Sekhon. Whenever you're ready, I'm here. I'm ready to go. But I don't want to, step on anybody's toes or nothing.
We are ready for you whenever you're ready.
Cool. Let me share my screen. I know it's a Friday night. You guys are all ready for some like socially distant activities. So, keep it up. Yeah, I won't keep you guys too late. Give me 1 second. All right, here we go. Can you guys all hear me? Yeah?
We can hear you and see your screen.
Perfect. So if you help me out, I'll get a sense of like where everybody's at in their training. But before, let me briefly introduce myself. My name's Navdeep Sekhon. I'm the clerkship director over here at the Baylor College of Medicine. I've been doing this for about 5-6 years, and I've had the pleasure and honor of advising students for this time period. So that's my background. About you guys, there's a fair amount of y'all, but maybe like with the raise hand function, can you raise your hand if you're an MS1? Two? Wow, okay. Anybody? Oh, there we go. Okay, and how about any MS2s? All right, good. And any MS3s? Good. And then your MS4s, and you haven't heard of these words, you're in some serious meaty talk. Anyways, so we'll get started. In order for the first things first, you guys are all muted. So we all have our favorite 4-letter word. So if you all can just yell your favorite 4-letter word on the count of 3. 1, 2, 3.
Food.
Good. I'm sure you guys all did it. I can't hear you, so I can't tell. Let me briefly put my video on so you can at least look at me. There you go. Hello. Sorry. All right, guys. So let's get started. We'll go through it pretty quickly. So the first 4-letter word is step. And step 1 is probably something you all heard of. If you're MS1 and MS2 or M2, you may be a little bit more surprised because step 1 is now pass-fail. This is a big change. Historically, step 1 was sort of a gatekeeper, and a lot of people didn't really like step 1 as a gatekeeper. Because of y'all who took step 1, does it really test stuff that's important to make you a good doctor? I don't know about y'all, but like the Krebs cycle, I've used about 0 times in my 10 years as an attending at Ben Taub. So step 1, questionable clinical relevance. Historically, the West Coast programs and like some of the more competitive programs would have cut off at 2:30. But a lot of programs didn't have a cutoff at all. I know personally, I know one chief resident who is an awesome doctor that I would love to treat any of my family members, got a 206 on his step 1. And so just keep that in mind as we go through the data. Step 1, going pass fail, could be a good thing, could be a bad thing. We'll go through the pluses and minuses in a few minutes. And yeah, so coming up, is it actually going pass fail 2021 or 2022? I thought it was 2021. Does anybody know? Good. Well, we'll figure that out later on. So step 1, going pass and fail, there's some winners and then some losers. The winners is step 2 CK, which to be honest is a more clinical exam, and it's probably more useful to figure out who'd be a good EM applicant. Clinical education, for now during your first 2 years, rather than studying for the shell, studying for step 1, students can actually spend time studying what's important to them to be a good doctor. Step 1 also forces residency programs to not use step 1 as a filter and view a more holistic approach to the student, which is fair, because just because you're a good test taker doesn't mean you're gonna be a good doctor. Since there are less things for people to look at, and it may benefit students from good medical schools, because less other things for students to look at. And then students benefit because they spend more of the first 2 years just learning to be a good doctor. Losers are students because perhaps now you only have one test, step 2 CK, and that's your gatekeeper. Like most programs get about 800 to 1200 applications. So they need a lot of times people use a quick screen. Not all programs do. Some programs do the holistic approach of every applicant, which I recommend. But a lot of programs use a number to quickly screen out a bunch of applications. So that's a possible loss. Basic science education may suffer because for the first 2 years, if your step 1 is pass fail, are you really going to cram till 2 in the morning every night studying? Probably not, because you get a high pass or low pass, nobody knows, not even you know. So that'll be different. Residency programs, these step 1 and screen will suffer, but that's probably a good suffering. And then IMs and FMGs will probably suffer as well because they have less data points to compete with US applicants. I talk really fast. You guys have any questions so far, or you guys are okay? Okay, so it won't hurt my feelings. If I talk too fast, just shout out. It won't hurt my feelings at all. People have told me that many times in my life. So feel free. So here's the numbers for step 1. This is based on the 2019 data. And you can see like how, based on your step score, what's your chance of matching. And things that I want to stress is that the average is around a 233, which is around over here. And you can see the average, greater than like 90% chance of matching, probably greater than 95%, pretty solid. But just keep in mind, even if you get greater than 260, you're like a rocket scientist, you know, you still don't have a 100% chance of matching because EM is one of those fields where we care a lot about your clinical ability and your clinical skills. And I bring that up because like, you know, like let's say you get between 200 and 210, not classically a great step score, but you still have probably like greater than 80% chance of matching if you get between 201 and 210, because these people are probably pretty clinically strong. So just keep that in mind as you know, when you look at your step scores. Just because you get a bad score doesn't block emergency medicine from you or for you. And here's another graph if you want to look at it real quick. And this typically shows your probability of matching based on your step score. And it shows around 220, you have a 90% chance of matching. And then and obviously it goes up as you go higher, but even if you get lower, like around 200, you still have about a 75% chance of matching, which isn't so bad given that step score. Step 2 CK. So as step 1 phases out, this will probably get a little bit more important. And here's sort of the scores and what the average score is. For an EM applicant, the average score is about 247, so which is pretty high. And over here, you can see like your odds of matching based on your step score. And you can see over here, and this gets us nationwide, the average nationwide for step 1 versus step 2, there's a 10-point discrepancy where step 1s are usually 10 points lower than your step 2. So just keep that in mind as you compare the two. And you can see like even if you get like a relatively lower score, like maybe like 225, you still have like a greater than 80% chance of matching. So just because you get a low step score, just keep that in mind. But even if you get a super high step score, that doesn't guarantee it. Because as we talk about later on, there's a study showing that having that slowies, your slows, are the most important thing that program directors look at on your application. Sorry, this is a lot of numbers, but it's just good to know like, you know, where you stand and know that no matter what your step score is, you have to do well clinically to be an awesome EM doctor. And to be honest, you want to be awesome clinically. Step 2 CS. Hopefully it's dead. I'm really excited that it is. I personally viewed Step 2 CS as a giant money grab from AAMC to make some easy cash because all your medical schools now all have OSCEs and are making sure that you're all, you know, have good patient relationships. So because of COVID, it's gone. This current class of graduating won't have Step 2 CS as a requirement. Going forward, it's up in the air. I know a lot of medical student organizations that are very vehemently opposed for it coming back because it's very redundant and most programs don't really care about it. You could fail Step 2 CS because you didn't wash your hands. That being said, in the era of COVID, washing your hands is very important. So I highly recommend that you all wash your hands. VSAS. I would argue of all the 4-letter words I'm saying, this one is the most stressful. And the reason being is getting an away rotation is part of the hardest thing, right? Because you're not guaranteed anything and there's not much information. Different programs have different start dates. So as you do your application, you guys all know about, you do one home, one away at the very least, except for this year. Make sure you have your ducks in a row for VSAS. Because this is, for my students at least, I've advised, this is probably the most stressful part. So just stuff you do before VSAS season. They have some vaccination requirements. Most of you guys have made that, but I've had a couple students who, didn't have their varicella titers, and that delayed their VSAS application season. So before you apply to VSAS, make sure you have your ducks in a row and make sure your vaccinations are all up to date. Another thing to keep in mind is spots fill up quickly. And the application opens up March 17th and you apply April 3rd, the spots will probably all be gone. So I highly recommend applying to a rotation that you really want to go to in maybe the first like five days of the application opening up. A lot of people have questions about where should I rotate? And that's like $1 million question. And some places to find programs, there's two websites you can use to find programs. One is the EMERA Match. They actually have a search filter for clerkships. And then there's the SAM Clerkship Directory. They're both good resources for you to use. And one thing I want to stress is that you're like, through your EMIGs or through your interest groups or TCEP, talk to other students who've gone through the system. A lot of them have very personal experiences about, different programs and, which programs really give you a good slowly, which one give you an awesome education, which one they felt sort of ignored. That's sort of very helpful. But just keep in mind, if you like a program, not all programs are on VSAS or VSLO. So make sure you Google the program and you might need to apply to some programs outside of it. Stanford's a classic one that is outside of VSLO. Any questions about VSAS so far? I'll just briefly address one question that I always get asked is, you really want to go to X program. And just because I go to Baylor, let's say it's Baylor, because I think it's an awesome program, but I'm a little bit biased. Let's say you really want to go to Baylor and you're like, you study at UTEP. And you're like, should I rotate my away rotation at Baylor? And there's two ways to play it, and here's my advice. If you think like you're strong clinically, you'll go there and you'll show off your skills and do well, you should definitely go there, 100%. If you think like you maybe not be that clinically strong, then you shouldn't. I sort of liken it to like, getting married. Like classically to the match, it's sort of like an arranged marriage, right? Like you sort of like make lists and then you suddenly like show up there. But like, your 4-week elective rotation, sort of like dating. You date for a while, you get to know them, they know you, and hopefully that sort of bumps you up. I know in my experience, programs tend to give more credibility and like people who rotate with them because you're a known quantity. Like we know that you'll work hard. We know that you're clinically awesome. So that's my thoughts on VSAS. So the question is, how many programs to apply per rotation? This is a good question. A lot of students are afraid that there are not enough spots for students out there. And that's false. There's actually enough spots. And if you do the math, every student applied to only 3 programs. Every student should get an away rotation. However, certain programs get more applications than other programs. So that 3, people throw that around, but it's not an accurate number. I would recommend maybe closer to 6 to 7 applications per spot. It's probably a good amount to try to get the spot that you need. Just to keep things in perception, like at Baylor, we probably have about 25, 30 students rotate with us per year. that are away rotations that we love to work with, we get about 430 applications. So just keep that in mind. Like certain programs get more applications than other programs. So just keep that in mind. All right. Any questions so far?
I had a question.
Uh-huh.
I'm a fourth-year med student, so applying this cycle. I was wondering, do you think, since the ways were so different this cycle, that most programs are going to rank a lot more of the people that rotated with them, like more so than a normal cycle?
So that's a very good question. And a good question means it's very challenging to answer. So I really appreciate that. Here is my 2 cents about this cycle. This cycle is very weird, right? Because historically, away rotations was a bread and butter of evaluating students and figuring out, this student's awesome, this student may not be as awesome. And now that's gone. And, because all of the big organizations recommended only one home rotation and no aways, in order to sort of prevent, some people trying to game the system. So like, let's say you go to Baylor, where our students are not allowed to do away rotations, and then another university, which allows your students to do away rotations, the other university students get an unfair advantage. So that is, sorry, what was your question again? I went on a tangent. I'm not sure I answered it at all.
Okay. So I was wondering do you think programs are going to rank a lot more people that have rotated directly with them compared to other cycles, as opposed to taking a risk and ranking people that haven't rotated with them, since most people only have one slow?
Yeah. So one thing I would say is that historically, I would say most programs, about 70% of the people that end up matching there don't do the away rotation. So in general, that's not a big thing. I think this year it'll probably be even more, because a lot of the bigger programs aren't allowing visiting students. So that's my 2 cents about that. Later on, we can discuss like how many places you should apply to, given the fact that, because of COVID, you're not traveling anywhere, and it's very cheap for you to go to 18 interviews because you can do it in the comfort of your own home. That's a story for a different, we can talk about later, but that's going to be a serious issue for the 4th years this year, is that figuring out how many interviews to do, because the barrier to interview is so low. Historically, it's expensive to interview, right? You got to fly somewhere, you got to find a hotel, you got to travel around the city. There's studies showing the average expense for an interview is about $250 to $300 per places you go to. Now it's about $0. So we'll see how that changes things, but economics sort of suggests people will apply to more places. The way we like to look at it, it's sort of like, I don't like to look at it, we are forced to look at it. It's sort of like mutually, it's like nuclear, like the Cold War, mutually assured destruction. Like we all know what the right thing to do is not build more nukes, but it's in everybody's interest personally to build more nukes, right? So hence every student cares about their self-interest. They apply to more places and interview more places, and nobody can fault them because it's in their best interest. Because you guys work so hard for so many years through like high school, college, med school, and now you're at the last step, you're not going to skip, right? I mean, it makes sense. Sorry. Cool. Good question. Any other questions? All right. We'll go on the next one. So other than this year, you need one home rotation course. You need one away rotation. That's the all you need. If you're an average to above average applicant, one home, one away is perfect. If you're a below average applicant, I would recommend 2. One thing that I recommend is people talk about like, hey man, I really want to live in California. So if you want to live in California or New York, I highly recommend, doing your away out in those areas. Other places is not so like region specific. Cool. And then, so it's sort of hard. So VSAS, we get so many applications. So, sometimes people like send letters to me to apply for a spot here. And I'm not gonna lie to you, I probably get about 100 letters. And I'm sort of busy, and those letters don't really persuade me one way or the other. However, if it's somebody that I know who sends me a letter, that means something. So just keep that in mind if you're asking for letters for somebody, ask for letters to apply somewhere. If you have somebody to send a letter on your behalf, but don't send it to like 5 programs, because you're gonna make people, you're not going to dilute the system. But if somebody you know really want to go somewhere, have them email on your behalf to the placement director. That can be helpful. ERAS, we're almost done. So you guys went through, got your away rotations, you guys rocked it, got awesome slowies, and now you're doing applications. Now in general for ERAS, your goal is to get 12 interviews. Sorry, I'm thirsty. It's a Friday night. Before here, I was playing with a stomp rocket with a bunch of 4-year-olds. And you guys know what a stomp rocket is? Yeah, so it's a little plastic balloon thing you stomp on. It's attached to a rocket, and the rocket goes in the air about 70 feet. The problem is little kids don't know the concept of a line and waiting. So 3 kids got popped in the face with the stomp rocket. So yeah, it was not very ideal. But anyways, we digress once again. I have ADD, I'm working on it. So your goal is to get about 12 to 13 interviews. Studies show, analyzing data, is that you get 12, 13 interviews, your chance of matching is around 98, 99%, which is pretty good. This is historic and pre-COVID. I imagine personally that students, despite everybody saying not to do so many interviews, are going to do more interviews. It just makes sense. So I'd probably recommend doing maybe 3 or 4 more interviews, maybe doing 15 or 16. I'm not going to lie, most of your advisors will say 12. And that's what all the major organizations are saying. However, I do not conceive that many students are going to do that because it's in their best interest to do more interviews, and the barrier to interview is so low. I imagine that they'll do more interviews. So that's my 2 cents. Now, the other question is how many places to apply to. And one thing I want to stress is the most important thing in this whole entire process, because this whole entire application thing is a new game to you, right? You're learning the rules as you go. Having a mentor to guide you and show you the rules is key. So it is very, very important that you guys find a good mentor. If you have one in your own institution, that's fine. If you don't, what's that called? EMRA. EMRA has an organization. You might want to join it. And they also have an advising service, which can be very helpful for you as well. And to be honest, most people in medical education love teaching, love advising. So if you know somebody in another program, reach out to them. Me personally, I love advising. My email will be in the last slide. If you just want to talk and I can give you some advice over the phone or mentor, I'm happy to do that. Because I know a lot of programs don't have EM residencies and that's unfair. I want to make sure everybody has a fair chance, right? That's how things should work. But you want a mentor who will give you honest feedback. It's very easy for somebody to say, oh, you're doing great, you'll be fine. But that's not what everybody needs to hear. You want a mentor to be able to tell you the negative things as well and tell you your realistic shot of matching in emergency medicine. Because you guys have worked hard for so long. I can't stress that enough. I know all of you guys work very hard. You don't want to not do well at the very end just because you didn't get the mentoring you need because somebody's being nice to you. So just keep that in mind. And trust me, I'm not very nice. I'm just kidding. So just keep that in mind. So historically, pre-COVID, the average number of applications for the average applicant who matched was around 30 to 40. So that's the number of places. And to be honest, the average applicant matches in the top 3 in the rank list. So despite all this over application we're doing and over interviewing, people tend to match where they want to go. So hopefully that's reassuring to you all. So this year for the MS4s, this is a challenging year because people will be applying more. So because they're applying more, should you apply to more spots as well? And that's a personal decision I leave to you because this year is sort of like the Wild West. All the rules are being remade. Hope it's very comforting to you because it comforts me about 0. But I would say, I applied to 15 or 20 more than I would have in past years because I know everybody's applying more and everybody's going to be interviewing more. I don't foresee students not doing that, and I don't blame them for not doing it either. So I'm advising my students here at Baylor personally to apply to 15 to 20 more than they would historically.
I have a quick question. Interviews.
Hit me up.
I'm Jacob, a 4th year. Do you know if there's going to be any official cap to interviews as far as the amount that you can have? 'Cause
Yeah. So I'm on like the program director listserv, the clerk director listserv, and there's a bunch of talk about how this is a problem this year. We all know this is going to happen. So the question is, how do you do it? There was one, I'm going to a little bit nerd talk, but hey, whatever, I'll let you guys know. So in the background, there's a lot of talk about using a vendor where every student gets 12 coins, and that's how you can limit the number of interviews. That coin system had a lot of drawbacks, because like if everybody chooses the same 12 program for the 12 coins, they might just be out of luck. So that's sort of like, a bad thing. And then the company that used the coins was very shady, and their marketing videos featured Beyonce. I'm from Houston, so like I'm naturally like pro Beyonce, but apparently like nationwide, that wasn't very well received as professional. So that's gone. So they're still talking about it in the background, but honestly, we're so close right now. I don't see any way where they can reasonably limit the number of interviews that students go on. They're counting on advising to do it, but advising has no force, right? Historically, even pre-COVID, students always applied more than what advisors said. So that's that. There was some thought regarding giving each student 2 tokens to show programs that they would like those 2 programs. ENT has done that before. Ortho tried it before, and it's been done a lot in economics, but it didn't really work out for those programs. So I don't foresee it happening in emergency medicine either. That's a great question. Hot topic.
That's really interesting. Thank you so much for being transparent about that. I appreciate it.
Nah, dude, you guys need all information you got. This year's a crazy year. Any other questions? Perfect. So I'm looking at chat real quick. So I recommend like around 6 or 7 programs apply for VSAS in order to try to get a spot. And yeah, as Ms. Sheikh mentioned, expectations for COVID. I think everybody's expecting people to apply to more places because that's just human nature and it makes sense. I think like some programs are even planning to interview more people than they did before, realizing this is happening. I feel really sorry. Oh, sorry,
Go ahead.
Yeah, no, I feel really sorry for this MS4 class because you guys are having a lot of stress that's totally out of your control regarding applications because everything's new and being remade. So best of luck to y'all. Sorry, Ms. Pooja.
I just had a question kind of going off that last one, since it's kind of expected that there's going to be a lot more applicants to each program this year. Do you think programs are going to try and put in like stricter filters to go through applicants to kind of cut that down, especially since you guys have like a whole month less to look at applications?
Mm-hmm. Yeah, so regarding the filtering, I don't think the filtering will change. To be honest, I imagine that it's also cheaper for us now because we don't need to like wine and dine you guys. Not that we actually gave you very good things at Baylor. We're a county hospital. We don't have much money. But it's cheaper for us. So I imagine most programs will interview more people to make up for it, realizing what's going to happen. To be honest, this is all my personal take. Talk to as many people you can about it. It's a very challenging year. But from what I'm seeing, I think that's what's going to happen.
Thank you.
Oh, no worries. Cool. Any other questions before we go forward? I love answering questions. Cool. Well, we'll talk more at the end. So now we'll talk about slowies, which are a big deal. So there's a study done. This was done in maybe 2012, 2013. Oh, 2013. And it interviewed a bunch of program directors and asked them what was important to them when they decided who to interview, right? Because that's your foot in the door of places where you want to go. And it's actually pretty good, a 94% response rate, which is pretty high for any survey that you email out to people. And slowy was the slower you're slow was the top deciding factor in who to interview. Question for you guys. most of the country, do they say slowly or do they say slow? It's a very important question.
It's slow. Most
Slow.
Slow.
Yeah, slow.
Slowly
So most
doesn't
of the
sound
country,
as scary.
yeah, very good. So most of the country says slow. Texas, for whatever reason, a lot of people say slowy. So if you want to give somebody that a dead giveaway that you're from Texas, you say slowy. If you want to keep that fact under wraps, if not proud for being from Texas, I don't know what's wrong with you. Say slow, and then you can move. I'm just kidding. Okay, so slowy is number 1. Your EM grade is number 2, and then number 3 was your step scores. And this just stresses, I said earlier, is that in your emergency medicine, we want great clinicians, we want people out there who can take care of patients, treat them with compassion and have good interpersonal relationships. That is key to emergency medicine. So just keep that in mind. There's some guys who may not have the greatest step scores. Remember, if you're awesome clinically, you'll be just fine. So here's a slow, and here's the second page of the slow. And briefly, like every academic emergency medicine program does this for all the students who rotate with them. So, everybody does their home rotation and their away rotation. They get this filled out. And a lot of you guys will have heard about middle third, top third, and lower third. So just keep that in mind. And what they're talking about is over here on the left, on the very bottom, you'll see top 10, top third, middle third, lower third, all this stuff right here. So we give everybody a ranking. And what you can see is that, when we look at these slowies, like let's say like choose random university, Baylor. I'm biased. So let's say Baylor gives everybody top 10s. So if I put top 10 here, and over here last year, 40 people got top 10s and 0 got the rest, I know top 10 from Baylor doesn't mean anything, right? Because everybody gets top 10s. However, let's say another university, say University of Houston, let's say UT Houston, and they have 5, 5, 5, 5, and they're pretty, they used this appropriately, and getting a middle third from them, that means you're an average applicant, which means you're probably pretty good. So, this is very important for us to help sort of decide how to interpret the numbers. And over here, you can see where they put them on the rank list. One thing to stress is that a lot of students get very worried about the lower third, and they think that a lower third is a death knell for you to get an emergency medicine. And that's a very reasonable concern. I totally get it. But one thing I want to stress is that studies show that about 75 to 80% of people who get lower third still match in emergency medicine. So just keep that in mind. Even if you get a bad slowy, if you do another rotation or you have other attributes, that can still allow you to match in emergency medicine. And most people in lower third still end up matching in emergency medicine. So just keep that in mind. Of course, you get a lower third, you may want to apply to more places, which is why it's important to get good mentorship. You need mentors out there to sort of gauge your skills and be realistic with you when it comes to applying for applications coming ERAS season. And then there's these boxes up here about various other stuff regarding student applications, student attributes. And to be honest, we say in our side, we go mostly left box, middle box, right box, but this isn't really as important as stuff over here. So just keep that in mind. One thing I want to stress to you guys, as you guys do your home and away rotations, there's a comment section where the team can write 250 words about you. And there is some code words that can tank your application. And most of those code words that tank you is not about medical knowledge, because we believe everybody can learn to become an emergency medicine doctor. It's not about, your test scores. What tanks you is your interpersonal skills and not treating people with respect and being arrogant. So what'll tank your application if somebody writes those words about interpersonal relationships, being arrogant, not being humble. That's something that's going to tank your application. So I'm not sure, I don't know you guys at all, but if any of that's a possible issue for you, try to keep that under wraps and work on that before you do your home rotation, because that's what usually tanks people in the comment section. Any questions so far? As I talk about sad things.
I had a question. You said that after slows, it was probably the EM grade that was the most important. Could you talk about the difference between the two?
Yeah. So to be honest, there really should not be a difference. Because like if you get a top 10, you should honor the rotation, right? Like if you don't. However, I know for myself personally, a lot of times you have your clinical scores that you get from every shift. Like most programs out there, you have a shift card, and you do your shift every day with a different attending. They fill the shift card, and that makes your grade. However, let's say you're unfortunate enough to work with. You guys ever heard of hawks versus doves? No? Okay, good. Oh, interesting. That's a main beef of a lot of students. Anyway, so hawks and doves. Some attendings will get, let's say like a 10-point scale. The hawks gives everybody a 5. You know, hawks is like, dude, like my standard for being a 10 is like, you know, being the next like Fauci, right? And you know, some people are doves, you know, they're like hippie, I love everyone. Everybody will make a great doctor. So the average student for them gets a straight 10. So a common complaint from medical students is like, hey man, like I worked with a bunch of hawks, now my grades unfairly low. And a lot of people will recognize that's an issue. I'm sure if you guys go back to your rotations and think about it, that's something that might be an issue for you all. So to be honest, like a lot of times, like if somebody is an awesome student and the grades are less than, their shift cards are less than awesome, you know, we'll give them a top 10, top third, because we know that grade isn't reflected. So to be honest, I would say the SLOE means a lot more than the grade. That makes sense? Cool. And then in terms of SLOEs, there are a lot of different kinds of SLOEs. The best kind of SLOE is the group SLOE. And the group SLOE is usually done by a group of people. Classically, it's done by a program director, clerkship director, assistant clerkship directors, APDs, educationally minded faculty, and a group of people discuss every applicant and assign the SLOE's numbers. This is the best way because you have multiple people evaluating an applicant or evaluating a student, and that way you don't have personal biases, right? Everybody has a personal bias. So you have more people, it sort of limits that personal bias. Not as good as an individual SLOE, where you get an individual faculty that writes a SLOE, and you know, individual SLOE doesn't carry as much weight. That being said, SLOEs that carry more weight is SLOEs from people you've heard about. Like in Texas, we're a pretty close-knit community. So like I know what a SLOE from University of Houston, from Southwestern, you know, from JPS, I know what those SLOEs mean. But like, do I know SLOE from somebody in University of Nebraska means? Not necessarily. So just keep that in mind when you choose places to do it. The more well-known the program is, or like, the more likely people will know what the SLOE means. So this year, because of COVID, there's a lot of different kinds of SLOEs. So let's go briefly through different kinds of SLOEs. Sorry, I'm Texas. I use the word SLOE, not slow. I apologize. So first off is E-SLOE. And this is the traditional SLOE. This is done by academic faculty at an EM residency. So when you do your home rotation or away rotation, that's associated with the EM residency, you chose the EM, the E-SLOE. The regular SLOE, I know this is mildly confusing. There's a website, you know, where you can go into details, but this year is sort of weird. I apologize. The regular SLOE is for faculty at an EM place that doesn't have an EM residency. So let's say your home place doesn't have an EM residency, and one of your faculty there writes you a letter, it would be a SLOE, not an E-SLOE. Now this year, there is now an O-SLOE for off-service people to write SLOEs about you. So this is a way to try to standardize that. I know this O-SLOE thing is giving students a lot of stress because they're like, I need to get these people to do it. I asked them to do it. They have no idea what I'm talking about. So a lot of stress. To be honest, I would still get O-SLOE, but I know me, myself personally, I'm not gonna give much credence to an O-SLOE because like I guess that most students are smart and intelligent, which all of you guys are, and you're gonna ask letters from people who like you. And the people like you will write you a good SLOE, O-SLOE. So like, I fully imagine that most of these O-SLOEs will be like glowing reviews of how awesome you are. That's not as helpful as like a group SLOE where people are like sort of like more actively like comparing you to prior years, and I have prior years data of how you evaluate students. So that's the O SLOE. And the last kind of SLOE is a SLOE subspecialty. Some places have like EMS, tox, wilderness medicine. If you do those kind of rotations, you can get the SLOE dash subspecialty. Is that enough kind of SLOEs? Only 4? Yes, it's going to be a fun year, guys. All right, so some brief tips before you go on your rotation. In general, remember your rotations are your audition rotation. So this is where, you know, you show up prepared. So you read up beforehand. So day 1, you hit the ground running. Stuff that our students use that they really like is EM Basic. EM Basic students love a lot. It's a podcast. EM Secrets is a book that people use that they really like. First Aid for Emergency Medicine, I think is too basic. So I wouldn't waste your money on that. But your money, you can do what you want. And then ROS Review, if you have like SAM test or end of course exam, ROS Review is pretty helpful for our students. It costs about $40 for a month. So a lot of our students do that and are really happy with it. For your shifts, show up early, leave late. You know, you're there to hustle and show everybody how awesome you are. One mistake that a lot of students make is they think if I see like 20 patients a shift, I'm going to be a rock star. And to be honest, they see 20 patients, but never take ownership of their old patients and don't reevaluate them and don't know what's going on with them. And that's not helpful for the team. What I recommend is take ownership of your patients. And rather than seeing a bunch of patients, reevaluate patients once an hour. You know, update your patients regarding their care plan, the results, educate them regarding the disease process, and then update the team with what's going on with your patient. That shows the team that you're, you know, taking ownership of your patients and you're actually acting like a true intern. So that's a common mistake that I see a lot of people who go into emergency medicine make. And then like a general thing is like, you want the team to be happy that you're there. You're like, man, that student made my day easier today. So that's a quick tip for your rotation regarding that. All right. I talked really fast and went through a lot of stuff. Anybody have any questions or anything you want to discuss?
There's a question in chat. You can see if you scroll up a little bit from Travis Odom. That's a pretty good question.
Okay, well, what question was it?
Travis Odom asked, some of us won't have our shelf combat scores until well into November, December due to unfortunate core rotation scheduling. Could this be detrimental to our interview chances?
Just for your, I'm assuming it's for your EM course, right? So not really. So what matters more is your SLOE. Your SLOE should be in by then. So the fact that you lack that test shouldn't negatively affect you at all. But I would hope that your school work with you to do this stuff earlier, but that's above my pay grade.
I have a question. My name is Bihan. I'm a third-year medical student. For those of us in the class of 2022, for that application cycle, there are going to be some students that have a step 1 score versus those that just have the pass-fail labeling on that exam. While I understand that step 2 CK is going to be weighed more heavily for all students involved, what is your impression of seeing like a numerical score to that step 1 value? Does that make you, you know, have more like trust in that student's abilities, or? Yeah,
so this is a very interesting year, and thank you for asking a very challenging question. You guys are awesome with the hard questions. Keep it up. And you also ask questions where it's hard to be PC, but whatever, it's Friday night. So here it is. If you have data that's in front of you, it's impossible to ignore it, right? Like as much as people say it shouldn't matter, like if for the past 10 years, I've been looking at step 1 scores. If I look at step 1 score in front of me, I will note it and it'll color my view of the application. In my mind, I'll say I'll focus more on step 2, which I will historically have. But once you see it, it's hard to undo it. That being said, I don't think having a pass is going to hurt you, if that helps at all.
Thank you.
I had a question. You mentioned at one point that group slows are better than individual slows. Is there a resource, or how do students learn which programs write group slows versus which write individuals? That way maybe they can target them on their VSAS applications.
That's a very good question. So one thing I would state is talking to other medical students is so important. Like most EMIGs have like a little spreadsheet where they go through all the rotations they've went through over the years, and they say the pluses, minuses, how their experience was, and the quality of the slowie. That being said, most EM programs do group slowies because we know that students travel all the way out here to get experience. We want to make sure it's fair to them and they get the group slowie that they deserve. I would say nationwide, very few EM residency associated programs have individual slowies. Thinking at the top of my head, last application year, I can't think of one. So hopefully that helps. Any other questions? And feel free to put in chat box if you want.
I have a question.
Oh, go ahead.
So compared to previous years, you were talking about having one home slow as well as one away slow. How is it going to be different this year in regards to COVID and the one slow opportunity a lot of us have?
Yeah, so it's very different. So one thing that I want to stress is that this is a new year, new rules. A lot of program directors feel very strongly that people should get only one slowie, and that's it. That's what everybody recommended, and trying to get more than one slowie sort of takes spots away from people from orphan programs. And orphan programs, if I'm familiar, are medical schools not associated with an EM residency. So a lot of people feel very strongly about that. So realistically, doing only one, we expect only one home slowie from everybody. If you get one home and one away slowie, and you somehow explain why you did it, that makes sense. You can probably get away with that. But if you got one home and two aways, people will think you're being selfish, and that would definitely negatively affect your application. So that's sort of how I view it. That being said, there are some program directors out there, and the listservs who say, hey man, if you do one home and one away, I'm totally cool with it. That won't affect it at all. I know some other people who say, hey, do one home, one away, that you're selfish, you don't need to do that. So it's very program coordinator dependent. But just keep in mind, what people say on listservs is very different than what they do in real life, right? Everybody wants to say the PC thing in real life, and the PC thing to say right now is one home and that's it. So I would say, if I was a guesstimate, I would say half of all people will say one home, that's it, and do more than one, you're being selfish. The other 50% will say one home, one away is fine. You're just doing what every medical student will do, trying to buff up your application. I can't fault you for that, because there's both sides of this, right?
Right.
But if you do more. Sorry, go ahead.
Oh, I had a follow-up question. Sorry if there was more to that. Just real quick. So since we got the one slow, would it be possible to do like a orthodox, letter of recommendation, or would you, would you suggest doing one of the individual slows along with that? Would you look at an orthodox, typical, just letter of rec? Is what I'm asking.
Good question. So this is how I personally will view it. A slowie is what I'm used to using for the past 10 years. I know what slowies mean. I know what a slowie from, like El Paso, UTEP means. I know what that means. That's gonna be way up here, right? And now the E-slowie from some random attending that I never heard of is down here, right? Or, a random letter of recommendation from them I never heard of is gonna be down here. I'll read it, but I'll be like, you chose a guy who likes you. Like, that makes sense. He's gonna write glowing things about you. That being said, if somebody who's like internationally well known, like if you get Dr. Goldfrank from New York to write you a letter, I'm gonna read Dr. Goldfrank's letter, right? Like Dr. Goldfrank's pretty internationally well known. I've heard of the guy, I've talked to the guy. I trust him. That being said, like Dr. Muck in San Antonio, I know the guy. If he writes a letter, I'm going to read it because like I know how he thinks, and that's helpful to me. So just keep that in mind.
Thank you.
Any other questions as I scan this chat box?
My question was kind of going off that. It was kind of similar. So for the one away rotation, that just pertains to like the e-slowy from a residency, correct? Like we could have one or two individual slows in addition to that, or how does that work?
Yeah, so this is like based per rotation. So like one group slowy per rotation. Cool. And then what if one slow is individual from an individual? Yeah, no, yeah, that's fine. So Mary, answering your question with that statement, Ms. Pujas, if you can get a group slowy. So when I'm talking about slowies, I'm talking about group slowies. That's the one that I'm talking about. You're more than welcome to get one group slowy and a bunch of individual faculty e-slowies from the same program. All right. Anything else?
And I had one more question, sorry.
No, feel free, dude. You know, because it's this COVID thing, I ain't going anywhere.
Yeah, this is super helpful. So, so I know you mentioned that you like have your slow, and that's the most important. And then under that is like your grade for the EM rotation. Is that something that's reported on the slow form, like the grade they give you? Because I know for our like EM rotations fourth year, on our transcripts from our school, they're technically pass fail. So they won't show up if you got like honors or high pass. So is that something that's on the slow form?
Yes. So on your slow form, it'll have the grade that you've gotten, and that in the past year, 100% of people on that clerkship or elective get honors, high pass, pass, and fail. So that way, like if you go to a place where it gives only pass fail, it'll be like hopefully 100% pass and 0% fail, and hopefully you got a pass. So that way you can sort of assess that.
Awesome, thank you.
No worries. And then Mr. Matthew mentioned end of third year versus fourth year slow week carry the same weight. And that being said, so third year versus fourth year carry the same weight. However, if you do a third year slow week and you get an early fourth year slow and you show great improvement, that's awesome. How if you do good on your third year slowy and then your fourth year slowy, you tank it or you do average, we'll be like, that's sort of interesting, like what's going on here? This is sort of, people usually get better as they advance to the medical training. So that'd be like a red flag that we look deeper into. And then full of good questions. Would a third year slowy, this is a good question. Would a third year slowy count toward your fourth year slowy limit? Probably not. If you do your home rotation in your third year, or like doing a away rotation, and then you do a fourth year, it's probably fine, but you have to be able to explain it away. People will ask you about it, and you say, hey man, like I did it early, like middle of my third year, and then opportunity, I wasn't doing anything else, so I did it. And you can sort of convince them that you weren't being selfish, you'll be just fine. Cool. Any other questions? Cool. Well, thanks guys. I really had a lot of fun talking to you all. Hopefully, you know, I talked about a few things to answer a couple of your questions. I know this year and in general, application cycle is very stressful. So like, I'm happy to talk to you guys about it, like, you know, via email or some other time. My email's on the screen, so feel free to send me an email and we can set up a chat. I just want to make sure that you all match wherever you want to match, and you guys all do awesome, whatever you guys choose. Thanks everyone.
Thank you, Dr. Sekhon, for your talk today. We hope everyone learned something about how to apply to emergency medicine and be the best applicant you can be wherever you apply to residency. Lots of great pearls from these two presenters today. If you're interested in referencing back to these PowerPoints, we'll be making these recordings available to you shortly. We've had a great past 2 days of the colloquium, and I just want to plug some of the events we'll be having tomorrow, our final day of the conference. So tomorrow we'll be starting a little earlier. We'll have health policy discussions at 9 a.m. tomorrow. And you just refer back to Blake's email for the links to that. We'll also have qualities of a student who honors a clerkship, as well as getting into residency by Dr. Todd Berger tomorrow. And finally, our PD panel, along with a residency fair, will be tomorrow at 2 p.m. So we're excited for that. On that note, we'll be having a practice run for our residency fair right now. So if you're available, we'd love to borrow you for the next 5 minutes. But otherwise, thanks everyone for joining us today, and have a good night.